we'll start with your presentation, and Jody will guide the Q&A during presentations and transitions.
Okay, thank you very much for your kind introduction. All right. Okay, so we jump right into my case report. I have a patient, a male patient, 70 years old, with dilated cardiomyopathy and severely reduced systolic function with an ejection fraction of just 31%. As you can see in the echo picture, we have a huge left ventricle. So as you would expect with this disease. The patient has an implanted ICD since 2004, and he had since then multiple adequate shock deliveries in ventricular tachycardias. He also had 3 previous ablations, and the last ablation, before the ablation we talk right now, it was just 3 months. And now he got another indication for a sustained VT with an ICD shock delivery a few days before the ablation. Here we have the IAGM from his ICD of the ventricular tachycardia. We had no 12-lead ECG available from his last VT. His baseline ECG was a sinus rhythm with a wide QRS complex, as you would expect in such a patient. There was no special medication, just everything what you would expect. So we decided to do a late enhancement CT with the patient and to send it to the inHEART platform. And what we got from there was the report of this diffuse wall thinning, especially on the inferior and posterior LV wall. And as you can see here, there are some critical isthmi that you can already see from that picture shown here. And what we also got was from the late iodine CT was this transmural scar distribution in areas where the previous ablations were performed. So just what you would expect from here. While mapping during the procedure, we could not induce any sustained VT with programmed ventricular stimulation. We had some late fractionated potentials while mapping on the pentarray signal here. Also on the late potential here in the BART system. But as you can see, we just got this huge low voltage area where we couldn't, which is not too differentiated, but just red and nearly dead. So we focused on the inHEART CT and the wall thinning map that we got from inHEART, and merged it with our map, which is not like it's just a small part of the LV because it's so huge, but we overlaid it and tried to focus on these isthmi that we got from the report. So the 2 isthmi we see here and here, that was our main target for the ablation. We focused on that, and also the scar area, which is a bit more darker green in this area. We focused on that and did a bit of substrate modification on interesting signals, as I showed before, that were right here. And so all in all, we had around 40 minutes of ablation with 48 watts average power, and most of the energy was delivered to the isthmi we saw on the inHEART CT. So in summary, we had no induction of the VT before and also not after the ablation. We didn't have any 12 lead ECG of the VT, which would be helpful. We had this huge low voltage area in the left ventricle, and we just saw a few late potentials during mapping, but not many interesting signals there. But with the help of inHEART, we had a clear ablation goal that we could pursue and that we just followed. And since then, since the last ablation, that was around 14 months ago, there were no sustained VTs or non-sustained VTs in the ICD memory of the patient. So we were interested because we had a few of these cases, and we wanted to compare them to cases we did before, but without the inHEART report. And as you can see here, the results already indicate a clinical benefit of the inHEART based ablation, especially for non-ischemic VTs where you don't have this or you don't often have these clear targets for the ablation. Yeah, thank you very much.
Thank you, Florian. So I will open it up to our other panelists here to ask any questions, and then also to the audience as well. If you are an attendee and you have a question, please feel free to submit it in the chat or the Q&A function, and we will work that into the conversation as well.
Maybe I can start.
Sounds good.
Thank you.
Well, thank you, Florian, for this interesting case, which illustrates the nightmare that non-ischemic VT ablation can sometimes be. Usually, with imaging, we can show substrate that is non-visible on mapping. Here, you had a lot of substrate on EP mapping also. I think one interesting thing about your case is that it's a quite unusual case for a DCM. This severe thinning that you saw that allowed you to even define channels of potential VT circuit is not common. It's usually seen in post-infarction, but not really in DCM. It's rare. When you see that, the dark red here is 1 millimeter thick. So usually in DCM, you have a diffuse thinning that is mild to moderate, but it never goes down to 1 millimeter. When it does, it's usually suggestive of post-inflammatory scar, I would say so. So it's probably an old chronic remodeled myocarditis, and then it behaves a bit like an old infarction. You know, there's clearly areas of total block around which arrhythmia can perpetuate. But your strategy was very interesting. The only thing is, I did not get how you registered the data. Was it on the electroanatomical geometry of the LV, or did you acquire also the great vessels to fuse?
Yeah, usually we register with the aortic arc, and sometimes, if possible, we have a look at the arteries. Or the ostium of the arteries, and that's usually enough to merge the image.
Okay, good. And a last question: since the patient had undergone multiple prior ablations, why did you decide not to opt for an epicardial approach?
So, because
I mean, either epicardial or via the CS. We see that there's a CS branch, so that may be interesting to catheterize here. Obviously, you didn't have the VT, but
yeah. So the patient had like a catheter, like the last catheter was a few month ago, I think. So there was nothing there, and because of the last ablation, where we did a substrate modification in a huge area on the LV without a really good target. We just decided to do a new approach and maybe get a good idea what to target for.
Makes sense. Thanks.
So, Florian, we've had a question come in from the audience, and the question is, there's not really precise CT channels with the EAM in this case. Maybe using other voltage scale in CARTO? Question mark.
Yeah, so that's the 0.5 to 1.5 millivolt is like our standard. We played around a little bit during the procedure, but we were not able to differentiate the low voltage areas enough. Like you can see pretty good in the inHEART, but while mapping, it was not too easy to differentiate, and also there were many extras coming while mapping with the pentarray, and so it was hard to get clean signals there.
One other thing I noticed is that you have beautiful late potentials on the signal that you show there on the screen. And sometimes you can re-annotate the map to show the late potentials, and sometimes the channels can even be shown in the voltage map with that.
Mm-hmm. Yeah. So yeah, so that late potential was quite, when we merged it, was quite here on the border of the wall thinning. So also so it was quite nice that it the merging was so good, because you would expect these signals in this area, I guess. Yeah.
Good. Any other questions for Florian? All right, well, thank you, Florian. And
Yeah.
we'll move over to Dr. Bourier.
Okay, hello everyone, Felix Bourier. Happy to present this case, and let me just start sharing my screen with all of you now. Now you should have it. So let's take a closer look together on this case of inHEART-based VT ablation in a patient with progressed dilative cardiomyopathy. It was a quite young patient, 52-year-old. His DCM was diagnosed in 2017 and ejection fraction of 45%. He then underwent ICT implantation in February 2019 after having experienced some hemodynamically relevant VTs. And then 3 years later, in July 2022, he experienced several ICD therapies within short amount of time, within 1 week. And with this kind of VT storm, he was referred to our center, and we decided to take him to the cath lab and perform VT ablation. And as you will see in the later slides, we now early go for inHEART-based approach. And let me share this approach with you. In the very beginning of the procedure, this is, I think, what all of us do. We do a programmed ventricular stimulation. And in this case, the VT was inducible with 3 extra stimuli. And as we didn't have a 12-lead ECG documentation, because it was all done by the ICD at home, and we at least could match those VTs with the IHEMs of the ICD and also the cycle length matched. So we were quite confident of having induced the clinical variant of the VT. Here you have the 12-lead morphology of it. And on the next slide, let's directly pass on to what the inHEART segmentation of this patient showed to us. Again, I think like in the previous case, as shown by Florian, one with a progressed DCM, especially in the inferior aspects, maybe post-myocarditis. You see the septal and apical part are not affected, but in the inferior part from basal almost to apical, we had these findings. And as I think, as you're all familiar with it, we can also bring in other important anatomic landmarks, especially when targeting maybe epicardial structures, procedures. We can also merge the arteries or the phrenic nerve. I just wanted to bring that in quickly for demonstration purposes. And as you see on this slide, it's just a mock-up of possible mechanisms that could be sustained by this substrate. And on the next slide, you see the next procedural step, very important step, the registration process. As you see here, registration was already performed, and it's very important to do that accurately because actually we want to get within a range of a millimeter accuracy. So if you do a registration, you always have to consider the correct registration landmarks. And my personal experience is that you should use some that are close to the heart. And in this case, took the aortic root, the coronary cusps, the proximal CS, and the apical LV. And considering those landmarks provides you a detailed 3D information that you can use to merge CT anatomy and mapping during the procedure in all three orientations. If you consider landmarks far away from the heart, let's say the spine, some bones, or the ICD pacemaker itself, it's always affected by, let's say, respiration, ECG gating. I think taking those will give you a great level of accuracy. And now let's move on to the next procedural step, and let's compare the substrate and voltage map findings that we have from conventional 3D electroanatomic mapping to the inHEART registration. Here you see the voltage map that was mapped with the pentaray catheter. In this case, you see healthy myocardium in the anterior, lateral, and septal part, and you see some tiny electrograms with a lower voltage in the inferior part. It matches to the scar, but all in all, you will see some electrograms later. The electrogram findings were rather normal. We didn't see a lot of substrate from there, at least not endocardially. And if you look at the propagation map, this was just acquired under sinus rhythm and normal ventricular activation. You see that also the electric wavefront in the ventricle is not bothered by the inferior substrate findings. You see some slowing maybe. So looking at the IEGMs in the scar area, I depicted this at the septal aspect of the matched inHEART anatomy. You see rather high voltage, you see some maybe delayed local activation, you see some stretch in the ventricular activation in this area, but not too much in another aspect of it. Again, you see high voltage, high amplitude in the near field electrogram, you see some delayed far field. The orange and blue electrodes look like they were not in good contact at this place. Those were one of the only findings that actually had in this area. Here you see the STSF catheter brought in. We had this electrogram, but in all other areas, actually, endocardially at least healthy voltage. Also, if you do some stimulation maneuvers like pacing from the RV, again, this was one of the only, at least a bit interesting electrograms. You see this on the left side, acquired by the ablation catheter, and during RV pacing, you'll see the separation a bit, but not too much actually. So I think next step, what most of us would probably do is pace mapping. And here you see that in the endocardial pace map at this site that is marked with the star, we had the best endocardial pace map was 89%. Why not higher? Possible reasons, maybe epicardial exit of the VT sequence. maybe some functional block during VT. When I was pacing a bit faster at this level, we increased the match, but maybe only to 92, 93%. And maybe during the sustained VT, we have a different myocardial activation pattern. And I think we all would agree that 89% is actually not a good pacemaker. So next step was applying the RF ablation based on inHEART segmentation. I think we didn't have nice electrograms, not too many. We didn't have a substrate finding in the electroanatomic map at all, or almost not at all. So we closed the presumed VT isthmuses based on the precisely registered model. And finally, after doing that, VT was not inducible anymore. We targeted most of the ablation at the area with the best pace map and in the area around, and in the based on the inHEART model assumed isthmuses in this area. I applied 50 watts in this area in order to produce transmural lesions. And VT was not inducible anymore at the end of the procedure. And now, last month, patient was free from VT recurrence 6 months at least after the ablation. So looking at the case, the patient experienced hemodynamically relevant VT. So for sure, there's a high necessity to treat it. The clinical VT was inducible. I think this is very good for success control, but it was not mappable. I mean, another solution would have been, of course, to do an activation map in this case, but we had to cardivert it because blood pressure dropped dramatically. You cannot do that in this case, and at least not if taking serious complications into account. I mean, another way would have been to use left ventricular assist devices, but again, very invasive. And it's, from my experience, much better for the patient and also for the team who's doing this kind of procedure to do it in sinus rhythm and to use the inHEART approach for it. And also the standard substrate-based ablation strategies we are used to didn't present any classic findings like late potentials. Pace map was quite bad, actually. We had no relevant scar in the electroanatomic mapping at all. And finally, we could perform the procedure with a rather low RF time of 40 minutes in this case. And we targeted this RF energy not only on the assumed relevant area of the VT, but also on other possible isthmuses, as you've seen on the segmentation and on the corresponding RF lesions in cardio. And yeah, finally, that resulted in acute and long-term procedural success. That's from my side, and interested in hearing your questions.
Thank you, Felix. Panelists, I'll open it up to you. We do have a couple of questions in the Q&A, but if Usha, Hubert, or Florian would like to start with a question, please feel free.
Could I ask one? Did you try unipolar mapping? I'm just curious whether you could see the effects on the CT scan with unipolar thresholds.
Yeah, we didn't see too much when switching. In this case, at least when switching to the unipolar voltage map and adjusting the thresholds, you saw it could have been a hint. You saw some scarring in this in the unipolar electrograms, but not that much that I would have targeted my endocardial ablation in this area. But of course, it could have been a hint to try an epicardial approach in this case as well. So maybe we would have seen it then. But again, I think it's in this case it may be elegant to do the inHEART based approach instead of switching to the epicardial axis. Especially, I mean, if we would have known it in advance, unipolar mapping, maybe we would have switched to the epicardial axis. In this case, for sure, I would do it in a possible redo procedure. But then ACT levels were already around 300, heparin was already administered, and then I hold a bit back with epicardial access.
Absolutely. I actually was asking because I've noticed in some of these non-ischemic cases, there's a discordance between the wall thinning and where the late enhancement is sometimes. And so I was just curious whether you could like verify at all that the wall thinning was important.
I think it's important, yeah. But in this case, we didn't spend too much focus on that, too much time on that. It was more a straightforward procedure to get it done. A
great outcome.
But,
yeah, that's great. I think most of the targets were probably on the epicardial side, right? This is why you didn't have good pace mapping and very few late potentials. Maybe there were plenty on the epicardial side. Was there a CS branch nearby? I didn't see that. Could you have looked in or paced from the CS?
Yeah, yeah. He did indeed. He did have. I didn't show it in the segmentation, but it's a good comment. Indeed, he had some CS branches there, but in this case, I didn't get my catheter inside. I think it's, at least for me, sometimes a bit challenging, especially in the dilative cardiomyopathy patients, to advance my ablation or CS catheter into those tiny branches. I think it would be easier probably if you have a specific, maybe small two French catheter for this. But in the dilated mitral annulus, sometimes a bit, technically at least, sometimes a bit challenging, I think. But probably we would have recorded beautiful electrograms there.
But it's a great example. If you hadn't had inHEART, you would have had to switch to an epicardial ablation during a redo because there was no way you can treat the patient.
Yeah, yeah. I think it's also maybe interesting kind of workflow to target the epicardial sites of interests by high power, long duration endocardial ablations, and thereby avoiding the epicardial access, which is sometimes a bit more risky than the endocardial one only. So I think it's maybe an elegant way to avoid epicardial procedure.
Yeah, and we've been publishing that a couple of years ago. The wall thickness on CT tells you whether you're able to reach transmural ablation. We've been doing that by reviewing our past combined ono and AP procedures. And we looked at all the endocardial ablation sites with a matching late potential or LABA epicardially to see when ablation was successful in eliminating the LABA. In fact, when you're below 3 millimeter, and this was the case in most of your target sites, you're able to reach transmural ablation. So yeah, so you didn't see the late potentials, but probably you destroyed them.
Yeah. Yeah, good point. Yeah.
So one question that we have from the audience is, and you've been speaking about the electrograms here. But in this case, voltage cartomap does not correlate precisely with CT channels. Maybe scale voltage again, or maybe excessive CT channels, electrical map dissociation.
Yeah, I think in this case, we didn't see any correlation at all. And this is why inHEART was so helpful, because the classic endocardial voltage map findings, they didn't give us any hint at all. I think this is because with the bipolar voltage map from the endocardium, you see maybe 0.5 or 1 millimeter into depth. So if the endocardial layer of your ventricle is healthy, even if like in this case, probably the VT substrate is right behind, you don't see anything. So no match between endocardial voltage map and CT integration. As we've just mentioned before, probably we would have seen some in the epicardial map, which we did not do.
And then the other two questions from the audience are very similar. They're related to registration of the inHEART model. And is there a standard technique that you're using in Munich for registration? And how has your technique evolved over time?
Yeah, so our technique included some kind of learning processes during the procedures and years. And the one that we currently do is the one that I showed to you. Let's see if I can quickly get back in my slides. Yeah, so I think you should be able to see it now again. And what I like is having at least 3 landmarks that are distributed in 3D space and that are close to the heart. In this case, the aortic root with the coronary cusps, the CS. In this case, I did only because, as just discussed before, it was just a bit hard to advance the catheter inside the proximal branch of the CS. It's nice if you can get the lateral and the distal parts of it as well, and or even some ventricular branch, and the apex of the left ventricle. And having those landmarks, you have a very high level of registration accuracy, because using those, you can align your anatomy in all 3 directions, in all 3 orientations of the space. And they are quite close to the heart itself. This means that the offsets that you will encounter are actually as low as possible. And what is nice about the aorta is that if you get a nice map of the cusps, you can already use those to get an idea about rotation. And same thing with the CS. If you have more branches of the CS, the lateral and the distal part, this also gives you a great orientation in space. And sometimes it may be challenging if you only have a very raw part of the aortic root or the mitral valve. You don't know how to turn. If you then have the left ventricular apex as well, this gives you a good idea how to rotate the heart in the longitudinal axis. And in the end, you will have a nice registration and a nice level of accuracy.
So Felix, what we are often advising the sites that are doing retrograde aortic access is to acquire on imaging the aortic arch also. This is usually quite helpful because it doesn't move that much, at least in diastole, it doesn't move that much so we found that quite useful. And another thing is, when not going retrograde aortic, when going transeptal, one very important message is not to register on atrial geometries.
Yeah.
The atria are much smaller at this end diastolic phase as what you will get on electroanatomical mapping. So one very, very accurate approach when going transeptal is to map the pulmonary artery and the 2 pulmonary arteries. It's branching, it's main branches, because then you have a rotation also that is fixed. And it's
totally
quite fast.
agree.
It's quite fast to acquire.
Yeah.
And ideally, when acquiring these fast anatomical mapping, so Usha will tell us that it's not needed when you have eyes, but when you're stuck with FAM, when doing that, the best is to use the ablation catheter and not a multipolar catheter to acquire these FAM. It takes a bit longer, but it's much more accurate in terms of localization. And also to set the respiratory settings of the carto quite strictly to really acquire geometries that are not impacted by respiratory motion. This is an important step, of course. And then on the CS, there's also one interesting hint, is to leave a catheter there during the procedure. So if you have to cardiovert the patient, or if the patient moves, you have this as a monitoring. If the catheter that was in the CS moves out of the CS, that means that you need to redo registration again. It's kind of a monitoring tool.
Yeah, very helpful points. Yeah.
Good. Thank you. Thank you, Felix. So if there are no other questions right now for Felix, we'll turn it over to Usha. And as Hubert alluded to, she's going to talk about a different style of registration in her case study. So Usha, we'll turn it over to you. And Usha, you're on mute.
Sorry about that. Thank you so much for having me. I was going to spend a couple moments talking at the beginning about just ice and the imaging that we can get from ice. So this is an example of an intracardiac echo image that's obtained from a catheter in the right ventricle. It's looking over at the left ventricle, and you can see an area of wall thinning here. You can also see a papillary muscle. This is a patient that had a circumflex territory infarction, and you can see that there's sort of a heterogeneous echo bright area in the anterolateral papillary muscle, and this patient actually had a VT coming from the anterolateral papillary muscle. So ice itself has a lot of benefits. It gives you real-time information. It can give you some information about wall thinning, maybe some information about fibrosis, and you can maybe see thrombus. We all know from CT, you can definitely see very detailed wall thinning. You can see fibrosis on late enhancement. You can see fat, and you can see thrombus. So I think that the two of them are synergistic and can work together in our procedures. This is an example of another patient. We're just looking over from the RV towards the LV. This is the mitral valve. This is sort of the lateral wall. You can see that there's a big, thin, fibrotic looking area on ice, but the extent of the voltage abnormality when we do voltage mapping is a lot more than what you see on ice. So most likely ice is going to underestimate the amount of substrate that's actually present. The other problem with it, let me see if I can get this to play, is this is a patient with a prior mitral valve replacement. And if you just look at areas that look bright on CT, you can get a little bit confused, particularly in the postoperative setting. This is a patient where, as we sweep the fan here through the lateral LV, you're going to see that there's a bright area along the lateral wall of the LV, going all the way from the apex back towards the base. And most of this is actually post-operative. You can see actually that there's preservation of the trabeculations of the LV in this area, and probably this is all just post-operative fibrosis in this patient, so it can be difficult to discern which is fibrosis and not. And you can see imaging here of the anterolateral papillary muscle in this patient. So when I'm going to do an inHEART scan, I have all my fellows learn how to make like a whole ultrasound map of the right ventricle and the left ventricle, and sometimes parts of the atria as well. So here we start with the catheter actually in the RA, and we can get some views of the lateral right ventricle. Actually, let me pause it there. With the tricuspid annulus, you can see the ICD leads start to go through the tricuspid annulus, and you can also see a mapping catheter that we have in there already. And then as we clock the catheter around and come into the RV, let me just back that up a little bit. We fill in the RV, and you can actually, in this patient who has an aneurysmal septum, you can get some views where you see the RV on either side, and you're just slicing through the septum. And this is starting to be the left ventricle here. And we're just slowly, with the catheter in the right ventricular outflow tract, just clocking it around. And as we come around further, you're going to see that we're eventually going to see LV contours. And we try not to, the tips of the, if we pause here, so you start to see the posteromedial papillary muscle right here. And when we draw the contours, we try not to take the trabeculations, but take it just a little bit inside the trabeculations. The contour that you're going to get is going to be a little bit smaller than what fills with contrast with the CT, no matter what. And you'll see that when we try to register it later. And then as we clock it around, you can start to see the anterolateral papillary muscle come in here. You can see cords, you can see the leaflets of the mitral valve. We can mark the mitral valve on the scan. And then as we come up further, we get the aortic root. And just like we were just talking about, we spend a lot of time on the aortic root. You can actually get several contours of the left main. This is the left main before it joins up with the left coronary cusp. You can get all the cusps from the point where I always say that they're like a little bit like a cup, that you can make slices of them going up and get a geometry of each of the coronary cusps. cusps. And so then to register with the CT image, this is just a plain CT. This isn't an inHEART processed CT. You can see how the fan of the image of the aortic root, you can see all the cusps here, and you can see some of the left main, how it goes nicely through the CT image, and you can use the anastomosis of the left main to really carefully decide exactly where the CT image goes. There are a couple places that are very hard to image with ICE, and one of them is this sort of infrabasal septum, and I usually try to get images from the right atrium. So here the ultrasound's in the right atrium looking over towards the LV. You see a transeptal catheter looped around towards the mitral annulus here. You can see the coronary sinus, you can see the mitral valve, and you can see this part of the LV, which is really hard to add to the map without getting a view like this. So when I'm looking for spots to register, I look for the coronary cusps, the coronary ostia, valve annuli, the coronary sinus, the apex of the LV, as we mentioned before, the RVOT, and then if there are ICD leads present, what's nice on ICE is you can kind of get them in real time, and it is helpful, I think, to help them with your registration. And then you can use, like, especially the anterior part of the LA, maybe with a little bit of the appendage, if you get it in real time, can be helpful as well. There are a couple places where ICE is not so great. And that's like in the infrabasal LV, that view I was just showing you on the previous slide, and then the infroapical septum. What you'll see on, actually, let me back this up a little bit. See how there's almost a bite taken out of the LV there? That's an area that, unless you really fuss with the catheter, it can be hard to get that full area covered. But then once we're together, you can see the apex lines up pretty well. All of the detail in the cusps lines up pretty well. And if we needed the coronary sinus, we would add it to that geometry. So that's kind of our workflow for ICE. And I apologize for taking some time. I'll just quickly do a case, which is actually a nice bookend to the cases that we've already had presented today. It's a similar aged gentleman with what thought to be prior myocarditis, VT, dilated cardiomyopathy. This is a population that I use a lot of inHEART because sometimes I have trouble finding the substrate on standard voltage mapping, just as we discussed before. He'd had multiple, I think 4 or 5 endocardial ablation attempts, and they were targeting 2 VT morphologies, one coming from an area that they thought was the anterolateral papillary muscle, and the second that was the infrabasal septum. And these were the 2 VT morphologies. And I agree that the VT1 morphology looks like it could be anterolateral papillary muscle. It's sort of negative-ish in lead 1, AVL. It's got a right bundle in V1. It's positive concordance, but not so tall in V6. So not terrible for that region anyway on the endocardium. The second VT, though, second VT has a lot of features that it might be epicardial, and I'll show you that on the next slide. But I just wanted to point out that there was very little voltage defect seen on the endocardial maps. So if we looked at that second VT morphology, we thought there were a lot of things pointing to an epicardial VT. So we went epicardial for our first map, and you can see here the merged, just the anatomy with the coronaries and the CS in the area of a small scar that we detected on the epicardium. And you can see the rest of the epicardial map actually didn't show much voltage defect. A lot of these are probably fat regions around the coronary anteriorly. What I like to do sometimes is just put the scar in then. And so what this is really nice because it shows that there's a mid-myocardial scar shown on the late enhancement images in an area where the wall thickness is pretty much normal. And it is much bigger. It's like an iceberg. It's bigger than what we saw in the epicardium and certainly bigger than what was seen previously on the endocardium. So it looks like this correlates really well with the substrate that we mapped on the epicardium, but you get the sense that there's a big mid-myocardial component as well because we don't see it fully on voltage mapping from the epicardium. So on these, we then mapped this area, which is pretty high up on the lateral wall. And when we paced there, we actually got that left bundle superior axis VT2, which is pretty amazing with a little bit of stim to QRS delay. So it's probably taking a course around the scar along the mitral annulus and then exiting out more septally, because you'd think with it being positive in one in AVL like this, that it would be on the septum. And then just a little bit up from that, so like from here to here, you could also get the VT1 morphology as well. So we were able to, we mapped with a decapolar catheter rather than a pentaray, but we were able to identify a little channel that went through that really little region of the scar. It paced a lot like the first VT morphology from there. So we thought, great. We even found a spot that we could get it to exit like both VT morphologies, one like VT1 and one like VT2. So we were so excited. We thought it was going to terminate from there. We induced VT and we entrained, and we could only find sites that had a really long stim to QRS during entrainment. And these were consistent with an inner loop kind of site rather than a real isthmus kind of site. And in keeping with that, we could terminate VT, but only after nearly 20 seconds plus of RF. So VT was still inducible after that. So we decided to go back to the endocardium. And when we were on the endocardium, we found these incredible late signals that weren't present previously. I think we probably modified some of what was on the endocardium by ablating the epicardium. And when you paced from there, you got these incredible long stim to QRS with the exit matching the VT, or this should say VT2, I apologize, the superior axis VT. We had great signals during VT there. And in contrast to the previous ablation that I showed you that took 20 seconds, this one in about 10 seconds terminated VT. In the end, our lesion set was targeted to cover the extent of the scar on the inHEART scan, at the entire extent, all the way from the most superior aspect of the mid-myocardial scar all the way to the inferior aspect. And when we remapped, it's very interesting, the epicardial scar got bigger. So I think we were actually sort of peeling away like an onion the normal tissue that was overlying the fibrosis that was present. So he's now 10 months VT-free off of antiarrhythmic drugs. And I just wanted to point out that this kind of approach has been published before by Pablo de la Bella's group for post-myocarditis VT with mid-myocardial substrate, that like covering that area that you think is involved in the scar is really important to success. Thank you.
Thank you, Usha. So I'm going to open up to the panel and welcome Professor Jaïs to the panel. So any questions for Usha?
Not from my side, just thank you very much, Usha. So I came in late, sorry about that, but it's a very nice presentation you gave, and I love the registration strategy that you have, and this is a very interesting case where, so in this case you had some substrate epicardially, but we know that in those non-ischemic conditions, it's not rare to have some intramyocardial substrate. And my understanding from the work by Katja Zippenfeld is that with a surviving ring of tissue, that you only need 2 millimeters of surviving tissue between the electrode and the scar to give you a normal voltage, or at least not to qualify for scar with current criterion. So I don't know if you want to comment on that, but I have the feeling that this is where having some pre-processed imaging is really very, very helpful.
It is really amazing because I think that's why our remap, when we remapped the epicardium after we were done ablating, the epicardial scar was much, much bigger, even without delivering epicardial lesions. Up here, we only delivered endocardial lesions from there. And this gets back to Dr. Bourier, I think, was making the point that maybe we can reach some of the epicardial substrate or block some of the mid-myocardial substrate and get transmural effects from the endocardium. So it's really interesting, and pretty clearly, like with a normal ventricle, you could never affect the voltage map in this way.
And how do you feel about having some image integration describing the substrate versus your ability to image that substrate during the case with ice?
I think they're both synergistic. I think they work together because the ice gives you the real-time thing. If something's changing, I've found just sort of anecdotally when I've done my scans, like for a while, I was doing my scans for the elective patients a long time before I do the ablation. And I feel like doing it really soon before is actually better, probably because maybe fluid status is similar, the ventricle is similar. And so I think that with any changes that might occur in the patient, if they were in AFib and then they go into sinus rhythm or something like that, then it can be really helpful to have the real-time information. And for intracavitary structures like the papillary muscles and stuff like that, I think ice is really, really essential for that.
Thank you very much indeed. And I apologize to Felix and Florian. I couldn't attend your presentation, but thank you. I've seen your slides, beautiful work.
I think Usha, this case is interesting because it's, or if you can show the slide of Paolo, where you have an MR image of a post-inflammatory scar.
Yeah.
It illustrates very nicely what you found on this case. Because in old post-myocarditis, we often say subepicardial scar, but if you look at the image, the MR image on the left, the edges of the scar go deeper in the mid-myocardial layers. So in the left image, it's on the inferior and septal side, and in the right image, it's on the lateral side. And each time you have an epicardial substrate, it's on the borders that it will go deep inside the mid-myocardial layers. So you should expect that. It's almost always the case.
Yeah, and the little fingers seem to just go on like in the
Exactly.
myocardium. Yeah.
And sometimes it goes up in the septum, and then it gets covered by the right ventricular fibers of the septum. So it gets a subepicardial scar will get intramural on the septum very often.
Mm-hmm. Absolutely.
Thank you for sharing this great case with us. If you do epicardial procedures, do you still see any need for performing a coronary angiogram or phrenic nerve pacing if you have the inHEART registration?
So in this case, we didn't do it. I would say that it's not always the case. In this particular case, there was not much in the way of coronaries in the area that we were interested in ablating. And we felt like our registration was pretty good. We weren't going to be coming anywhere near the main ostia of the coronaries. What I would say is that when we do the ICE imaging, we know where the ostia are really well. And like the proximal part of the coronaries is very reliable. I would say if, like, for example, if we wanted to ablate out here, I would probably do a coronary angiogram before, like supposing I was looking to ablate something right here, I would still do a coronary angiogram in that instance. But in a case like this, where I kind of know that there's this little bit of there's a place where there's not a lot of big coronaries there, and I have the registration fairly clearly, I feel like we did not shoot the coronaries in this case. But if for anybody that's worried and ablating epicardially, I would never fault anybody for shooting the coronaries in the case.
Along those lines, we do have another question from the audience. Usha, have you considered using ICE to display the bifurcations of the coronaries and the use of them for registration?
I don't think you can see them well enough. You can see, like in those case that I showed you where there's the long left main, you can reconstruct the left main pretty far down. You can get to the bifurcation of the LAD and the circ you can get on ICE. Sorry, I'm just backing it up here. Yeah, so you can get this part, you can get the bifurcation in some people. If you have somebody with a lot of coronary disease, you may not see those bifurcations so well because there's going to be calcification and shadowing there. In a person that has a valve replacement, it may be more difficult to see that. What's interesting is if it's a bioprosthetic valve, you can actually see the valve struts. So I've used that to help register before. But you have to be very careful in the setting of coronary artery disease, trying to make too much out of the ICE images because there's going to be some shadowing.
So any last minute questions from the panelist or the audience? We have had a very robust hour of discussions, and if there are no further questions, and I'm scanning and I'm not seeing any as of now. So I'd like to thank our panel of physicians. It's been wonderful speaking with you today. Thank you again for your time, sharing these great case studies with the inHEART solution and your experiences. To all of our attendees, thank you for joining us, for listening in. Certainly, if you have additional questions, please reach out to sales@inheartmedical.com. And to watch the videos from previous webinars, please visit our website at inheartmedical.com and select webinars from the references main menu option at the top. Well, thank you, everyone. We'd like to wish you a great day, and we look forward to hosting you again on a future webinar. Thank you.